Welcome to the deep dive. If you're prepping for clinicals, maybe studying for an exam, or just need to make sense of a dense medical chapter fast, you're definitely in the right place.
We aim to make it stick.
Exactly. So today, our mission is a real deep dive into assessing the skin, hair, and nails. This is such a critical foundation in med-surg nursing.
It really is.
We want to get beyond just the textbook stuff and show you what you really need to look for in a clinical setting.
Yeah, we'll walk you through the anatomy, the assessment cues you need, the diagnostics, and of course those key nursing interventions.
Okay.
But before we even jump into the layers and structures, let's just pause on why this is so important. Why start with the integumentary system?
Wait, it's the body's biggest organ, right?
Mm-hmm.
And its condition immediately flags two really high-priority concepts for this whole chapter: tissue integrity and infection.
Absolutely spot on. Think about it. The skin is your first, second, and third line of defense against pathogens. It's crucial for regulating temperature, maintaining fluid balance.
Non-negotiable stuff.
Totally. And when that integrity is compromised, your whole plan of care has to shift. It changes everything.
Okay, let's unpack that structure then. We've got these three main layers working together. If we think of the skin as this major organ system, the dermis seems like where a lot of the structural action happens.
That's a great way to put it, yeah. If we start from the inside out, the deepest layer is the subcutaneous tissue. That's mostly fat cells. Think insulation and, really importantly, shock absorption.
Right.
Then, just above that, you've got the dermis, sometimes called the corneum.
The dermis,
Yeah.
the powerhouse you called it. It's made of collagen and elastin fibers. Why are those two proteins so important for us to understand?
Well, because you see their effects directly in your assessment. Collagen, that provides incredible strength. It's why, when tissue gets injured, the body cranks up collagen production to make scar tissue.
Okay.
And elastin, that's what gives skin its flexibility, its bounce back. So, a key insight here. When a patient's injured, the goal is rebuilding collagen. When they're aging, the struggle is often about retaining that elastin.
Ah, interesting distinction.
And the dermis also has all those sensory nerves: touch, pain, itch, plus something called ground substance, which dictates how supple the skin feels. It's turgor.
Gotcha.
Moving outwards then to the epidermis. This layer's thin, and you mentioned crucially it doesn't have its own blood supply. It relies on the dermis below.
Completely. It
Yeah.
gets everything through diffusion from the dermis, and that connection is pretty strong. The epidermis is anchored by these finger-like projections called rene pegs that mesh with the dermal papillae below.
That's it all together.
Exactly. And inside the epidermis, you find two real powerhouse cells. First, the keratinocytes.
Keratinocytes, those are the basal cells, right? They keep dividing, push upwards, flatten out.
And eventually become the non-living cells of the very top layer, the stratum corneum. That's your horny layer, that waterproof barrier made of keratin. Tough stuff.
And the second powerhouse cell. That would be the melanocytes, the pigment producers. Now, here's an important detail you need to remember. Differences in skin color between ethnic groups aren't because some people have more melanocytes. No, it's about the size of the pigment granule, the melanin inside those cells. Darker skin tends to have larger granules.
Wow, okay. Same number of cells, just bigger pigment packages. And melanin's purpose is UV protection, right?
Precisely. UV light stimulates production. It's the body's natural sunscreen.
Fascinating. Quick question about the appendages.
Yeah.
Glands. The sebaceous glands make sebum. It lubricates. It's a bit bacteriostatic.
Yeah.
But wait, if sebum makes skin oily, why aren't my palms greasy all the time?
Huh. Good clinical question. It's because sebaceous glands are completely absent on the palms and soles.
Really?
Yep. That's why, managing really dry, cracked hands needs a different approach than dealing with oily skin on the face or back. Also, just a note on nails. Growth starts at the base, the lunula. Fingernails take about 3-4 months to replace fully. Toenails, much longer, up to 12 months.
Good to know for patient teaching. Okay, speaking of wear and tear, let's talk aging. We kind of expect to see things like ridges in the nails or that really thin, almost transparent skin in older adults. But what's the #1 cause of long-term skin damage?
Oh, hands down. Chronic sun exposure. Yes, hormones and genetics matter, but cumulative sun exposure is the single biggest factor driving the degeneration of skin components. It's the main reason skin looks aged.
Right. Okay, let's shift gears into assessment then, starting with history. You said the comprehensive history gives us clues about underlying issues. What are the absolute must-ask questions?
Well, you need the whole picture: medical, surgical, family, social history. But really zoom in on two key areas. First,
Hmm.
medication history. And don't just ask what they take, ask specifically if any skin changes started after beginning a new medication.
Prescription, OTC supplements,
Yeah.
anything.
Anything. Think about steroids causing thin skin, or easy bruising, or anticoagulants leading to, larger bruises, those ecchymoses. You need to know that.
Makes sense. And the second focus area,
Nutrition status. This is huge. Protein levels, vitamin deficiencies, they show up fast in skin health and especially wound healing. And hydration. You're looking for those cues. Is the skin loose? Does it tent when you pinch it? That suggests fluid loss.
versus maybe pitting edema, where it's tight and shiny from fluid overload.
Exactly. And then don't forget social and environmental risks, their job, hobbies involving chemicals, recent travel, especially to tropical areas, and always, always ask about sun exposure and tanning bed use.
Given the skin cancer stats, that's vital.
Absolutely. Prevention counseling is part of the assessment.
Yeah.
Okay, so now we move to actually looking inspection. You need good light, preferably natural light, and be systematic. Check all surfaces, get into the skin folds, scalp, hair, nails, mucous membranes.
And when we see something, a lesion, we need to classify it, primary versus secondary.
Right. Primary lesions are the initial thing, the first reaction, like a macule, which is just a flat spot, or a vesicle, like a small blister. Secondary lesions develop later. They're changes that happen because the condition progresses, or maybe because the patient's been scratched.
Like crusts forming over scratched blisters?
Exactly. Or skin become lichenified. That's that thickened, leathery texture you see from chronic rubbing or scratching.
Okay, now,
Mhm.
this feels really important. You mentioned a critical safety point earlier. The ABCDEs of skin cancer assessment. Let's slow down here. This isn't just for exams, right? This is everyday patient teaching.
100%. Every nurse needs to know this and teach it. So A is for asymmetry of shape. One half doesn't match the other.
Okay.
A, asymmetry.
B is for border irregularity.
Yeah.
Are the edges ragged, notched, blurred?
B, border. Got it.
C is for color variation. Does it have multiple colors within the one lesion shades of tan, brown, black, sometimes even red, white, or blue?
C, color. Okay. D is for diameter. Is it larger than 6 millimeters? That's about the size of a pencil eraser. Or maybe more clinically useful, about a 1/4 inch.
D, diameter, greater than 6 millimeter.
And finally, E is for evolving. Is the lesion changing in any way? Size, shape, color, elevation? Maybe it started itching or bleeding? Any change is a red flag.
A, B, C, D, E.
Yeah.
Asymmetry, border, color, diameter, evolving. Crucial. Now, what about vascular changes? We mentioned big bruises, hecchymosis, but what about those tiny pinpoint red spots, petechiae?
Yes, petechiae. They're critical because they don't blanch. If you press on them, they stay red, unlike some other rashes,
And why is that significant?
because it signals bleeding under the skin. And here's a major action alert for you. If you find petechiae, especially below the nipple line, it could indicate a really serious underlying clotting disorder, like disseminated intravascular coagulation, DIC.
Wow. Okay, so that needs immediate attention.
Urgent assessment, absolutely.
All right, so we've looked carefully. Now we need to touch palpation. We're feeling for consistency, temperature.
Gently, yes. Palpation confirms if a lesion is soft, firm, fluid-filled. And use the back of your hand to assess temperature. The skin there is thinner, more sensitive.
And we also assess turgor, right? Skin elasticity, pinching the skin.
Right. If it tense stays pinched up for a moment, that indicates poor turgor, often linked to dehydration or significant fluid loss. But here's a really important tip for older adults.
Okay.
Don't assess turgor on the back of their hand. Their skin there naturally loses elasticity with age, so it might tent even if they're well hydrated. It can be misleading.
Okay. So where should we check instead?
Check on the forehead or the chest. You'll get a much more accurate picture of their actual hydration status. That's a key action alert.
Definitely noted. Now, what's really interesting is how assessment changes with different populations. How do we assess effectively when someone has naturally dark skin where, color changes like pallor or cyanosis are harder to see?
Great question. We have to adapt our technique and know where else to look. For paleness, you need to check the mucous membranes inside the mouth. Look for an ash gray color. Lips and nail beds might look paler too, but the mucous membranes are often more reliable.
Okay, mouth for pallor. What about cyanosis, that bluish tinge?
Lips and tongue might look gray or whitish, but also check the nail beds, palms, soles of the feet, and the conjunctivae, the lining of the eyelids, for that subtle bluish tint. It won't be bright blue like on lighter skin, but you can often detect a difference.
And jaundice, yellowing. Is the eye the best place?
It can be, but be specific. Look at the white part right next to the cornea. Why? Because the rest of the square can sometimes have yellowish fat deposits, which is normal and can confuse things.
Ah, good tip. Sclera near the cornea.
Also, check the oral mucosa, especially the hard palate in the roof of the mouth. That's often one of the first places jaundice shows up, regardless of skin tone.
Excellent points.
Sure.
Okay, quickly hitting hair and nails. Hair. We look at distribution, cleanliness. What's hirsutism again?
Hirsutism is excessive hair growth in women, typically on the face, chest, back places. Men usually have more hair. It can be a sign of a hormonal imbalance, maybe something like Cushing's disease or polycystic ovary syndrome.
Got it. And dandruff you mentioned, it's often misunderstood.
Yeah, people often think it's just dry scalp, so they use heavy conditioners, which can actually make it worse. It's usually related to excessive oil production and sometimes a yeast-like fungus, so treatment is different.
Interesting. And for nails, we look for dystrophic changes, meaning abnormal appearance. What about clubbing?
Clubbing is that change in the nail shape where the nail base angle increases and the fingertips might look a bit bulbous. It's strongly associated with chronic conditions causing impaired gas exchange like lung disease or heart problems.
A significant finding then.
Definitely. Also, keep an eye out for acute paronychia, that's inflammation around the nail fold, often red, swollen, tender, usually caused by things like an ingrown nail or a torn cuticle getting infected.
Okay, so we've done history, inspection, palpation. Now, sometimes we need diagnostic tests to confirm things, especially infections.
Right. We move from our physical assessment to the diagnostic toolkit. Lab work is often needed, and you need to know how to collect the specimens properly.
Okay, let's say we suspect a fungal infection. How do we collect for that?
You'd scrape some scales from the lesion onto a clean slide or container. Then in the lab, they'll add potassium hydroxide, KOH solution. This dissolves the skin cells but leaves the fungi intact so they can look for those characteristic branched hyphae under the microscope. It's pretty quick.
KOH prep for fungus. Got it. What about bacterial infections?
For bacteria, you want to swab the exudate, the pus, or fluid, ideally from an intact lesion if possible. Sometimes you might need to gently unroof a pustule or vesicle with a sterile needle to get a good sample from underneath.
Unroofing, okay. And viral, like herpes.
If you suspect herpes, you'd use a special swab to collect fluid directly from a blister, a vesicle. Now, this is critical. Those viral specimens need to be put on ice or refrigerated immediately and sent to the lab quickly. Viruses degrade fast.
Ice immediately. Good point. And what test confirms it's viral?
A Zank smear can help. They look for multinucleated giant cells under the microscope, which indicates a viral infection, often herpes, though it doesn't specify which virus.
Okay. Now, sometimes we need an actual tissue sample of biopsy. You mentioned 3 types.
Yeah, 3 main types depending on how deep they need to go. The most common is the punch biopsy. They use a small circular tool like a tiny cookie cutter to take out a plug of skin. Usually needs a stitch or 2 to close.
Some punch biopsy, okay.
Then there's the shave biopsy. This just skims off the very top, raised part of a lesion. Good for superficial things. No sutures needed typically.
Shave biopsy, more superficial. And the last one.
Excisional biopsy. This is a deeper cut, using a scalpel to remove the entire lesion, often down to the subcutaneous fat. It's basically like a small surgical procedure and leaves a scar similar to one. Requires sutures.
Got it. Punch, shave, excisional.
Mm-hmm.
Now, after any of these, nursing management and patient teaching are key. What are the absolute must-tell instructions for the patient?
This is super important for preventing infection and ensuring good healing. First, tell them to keep the dressing dry and in place for at least 8 hours, no getting it wet initially.
8 hours dry. All right.
After that, they usually need to clean the site daily. Simple tap water or saline is fine. Gently remove any crust that formed, don't pick, just cleanse.
Clean daily. Use antibiotic ointment.
Yes, if prescribed, apply a thin layer of antibiotic ointment, then cover with a fresh, sterile dressing. And critically, teach them the signs of infection, increasing redness, warmth, swelling, pus, or excessive drainage. They need to report that immediately.
Report infection signs. Makes sense.
And if they had sutures, remind them when to come back to get them removed, usually in about 7 to 10 days.
Excellent. Okay, last couple of diagnostic tools. These ones are non-invasive. Wood lamp.
Ah, the wood lamp examination. It's basically a black light, long-wave UV light used in a totally dark room. Certain fungal and bacterial infections actually fluoresce. They glow specific colors under it, like some fungi glow yellow-green. It's pretty cool.
Helps narrow things down.
Right.
And diascopy.
Diascopy. This is simple but clever. You just press a clear glass slide firmly onto a red lesion. This pressure blanches the skin, squeezing the blood out of the superficial capillaries.
Why I do that?
It helps you see if the redness is due to blood within vessels, like inflammation, which will blanch, or due to blood outside vessels, like petechiae, which won't blanch. It helps reveal the true structure of the lesion underneath the redness.
Neat trick. Okay, wrapping things up, let's just quickly touch on some overall safety and quality care points related to skin integrity.
Absolutely. Simple things make a huge difference. Always use lift sheets when moving patients to prevent shearing forces on the skin. Strict hand hygiene and using standard precautions are non-negotiable, especially if tissue integrity is already impaired.
Good reminders.
And think about positioning. Help patients turn, keep skin folds dry, promote air circulation, simple measures to prevent moisture-associated skin damage.
So to recap the essentials for our listeners, mastering this integrated assessment, knowing the AMP, doing a thorough history, careful inspection, palpation, that's foundational.
Absolutely. And understanding those variations, especially how to assess diverse skin tones effectively, is crucial. Plus, prioritizing safety around lesion characteristics, those ABCDEs, and knowing that post-procedure care.
It really drives home that the skin is so much more than just a covering. It's this complex organ, a barrier, but also really a communication tool for what's happening inside.
Couldn't agree more.
So here's a final thought for you to maybe reflect on. The skin is our most visible organ. How does really understanding the psychosocial impact of visible skin changes, think chronic conditions like psoriasis or eczema or significant scars or even severe acne, how does that understanding shape your approach to truly patient-centered care?
Yeah, it's not just about the physical findings, is it? It's about the person living in that skin. Knowledge is the base, but that empathy, that's where the real application comes in.
Well said. Thank you so much for joining us for this deep dive today.
My pleasure.
We'll catch you next time.